Good afternoon, everybody, and welcome to Go for Life Partner Webinar number 3. My name is Stephanie Daly, and I am the director of the Go for Life campaign here at the National Institute on Aging. And I'm very pleased to welcome our partners from across the country to this webinar, our third one, as I've just said. As you can see from your screen, the title of the webinar is Physical Activity and Quality of Life in Adults with Intellectual and Developmental Disabilities. And we're very pleased today to have as our speakers and hosts of the webinar the following. Dr. Tamar Heller, who is professor and head of the Department of Disability and Human Development at the University of Illinois in Chicago. Dr. Seth Keller, who is co-chair of the National Task Group on Intellectual Disabilities and Dementia Practices. And Darcie Mersereau, who is vice president of health programs for Special Olympics International. And this is what we're going to be talking about today. We're going to give a brief update on Go for Life Month 2016, which just passed. It was in September. We'll have the presentations by the 3 speakers, and we'll have a Q&A and then a wrap-up. Just to remind those who may be joining us for the first time, and as a refresher anyway, Go for Life is an exercise and physical activity campaign from the National Institute on Aging here at NIH. And what is very important is to remember that Go for Life is research-based, and the goal, the mission, is designed to encourage older adults to make exercise and physical activity a regular part of everyday life. With Go for Life materials, older adults can learn about exercise and physical activity. There's a significant education core to Go for Life, the health benefits, exercising safely, fun activities, tracking your progress, sticking with it. We have about 85 of these tip sheets that form the core of our educational component for Go for Life. Adults can see and learn how to do exercises that have been specifically tailored for people 50 plus to be safe and easy for them to do through our online images and video. And then, of course, with exercise, motivation is always an issue. So we have a significant component of our program devoted to getting people motivated to exercise and to do it in a regular way and do what they enjoy. For Go for Life Month, which I promised an update on, which was in September, we had a theme of being fit for function. This is our second Go for Life Month. The first one was started last year, although the campaign is 5 years old. Go for Life Month began last year in collaboration with the White House Conference on Aging. And the Fit for Function theme focused on being fit in the 4 areas of exercise that we stress for older adults: endurance, strength, balance, and flexibility that you can see from this infographic that was developed for the month to commemorate the month. And if one is fit in all these areas, then it helps one be more functional to lead a daily life which makes it easier to be independent and to perform the activities one needs to carry out the daily functions of life. Also, in conjunction with Go for Life Month, we developed a video called Stay Independent with Regular Exercise. And in this video, it shows you exactly what the different types of exercise activities can help you with in terms of your daily activities. So in this instance, we see the thumbnail for this video showing how flexibility can make you more limber, improve your range of motion, and increase your freedom of movement, which leads to being able to do things like stand on your tiptoes, screw on jars, etc. So this video does that. And it's available on the National Institute's YouTube channel and the Go for Life website. You can get it there if you want to watch it and share it with your participants and members. For Go for Life Month, we held a Twitter chat on September 14th, and it was very, very successful. And we also videotaped Go for Life events that took place here in this area and a little bit further out from this area. And we showed the different activities, which included mall walking and community walks and exercise classes, all done to commemorate and to mark Go for Life Month 2016. And that video also is available on the NIH YouTube channel and on the Go for Life website. So you can get those there as well. We want to make sure that you remember that you can connect with us. We have lots of materials, and there are lots of things that you can find at Go for Life. One is our email alerts and our coaching tips. You can sign up to get free email alerts and free text to help keep you going and help encourage you and your participants and the members of your group to continue to exercise and to find unique ways to do it. And so these are very popular, and they're a prime motivational tool. And of course, you can follow us on social media, on Twitter, and on Facebook. So we want you to stay in contact with us, and these are just two different ways you can do that as reminders. So now I'd like to have us get to the section of the webinar that deals with physical activity and quality of life in adults with intellectual and developmental disabilities. And the first speaker will be Dr. Tamar Heller. And so I'm going to pass the microphone to her, and she can begin to give her presentation. Okay.
Hello, everybody. You hear me fine?
Yes, we'll hear you.
Okay, good. Okay. I'll be talking about promoting healthy aging of adults with intellectual and developmental disabilities. And a few things I wanted to point out about the health of older adults. First of all, they're a growing population. We're seeing if you look between 2000 and 2030, we expect that the number of people who are age 60 and over with intellectual and developmental disabilities to double. And there's many reasons for this. Many adults with intellectual and developmental disabilities, for example, with Down syndrome, used to die at a very young age, and now they're living much, much longer. However, what we are finding is often there's earlier age-related conditions. And these are many conditions that could be affected by certain behaviors that people have. But what we see that's often common, for example, for people with Down syndrome, we see dementia occurring at younger ages. We also see more osteoporosis in people with intellectual and developmental disabilities, and we see greater rates of diabetes. These are just some examples of what we see that often happens earlier in terms of age-related chronic types of conditions. We also see a greater risk of falls in this population. At the same time, we have an issue in that the health behaviors are often very poor. And that's, of course, what we're targeting in this webinar. We know for sure that they're much more sedentary, certainly not following the guidelines about the amount of exercise you're supposed to get. They also have poor nutrition. And as a consequence, you see higher obesity rates. And even though obesity rates have been increasing for the general population, they're increasing even more for this population. And you also see lower fitness levels, not surprisingly. Here's an example from a study from our Rehabilitation Research and Training Center on developmental disabilities and on health and developmental disabilities. And this is a study that we've been doing over a period of 8 years. It's called the Longitudinal Health and Intellectual Disability Study. And here's just some data from it that shows you the rate of obesity, 40.5% compared to the general population of 33.3%. So you can see that there is a greater rate of obesity. This particular study is looking over time at the impact of health behaviors on health status of people with intellectual and developmental disabilities. Here's some data around the insufficient fruit and vegetable daily intake. And you can see that insufficient intake is about 90% for people with intellectual disabilities, and much less, 75%, for people in the general population. And also some data we have on the physical inactivity. And you could see 83.6% in comparison with 47%. So these are pretty dramatic differences that we see in people who are aging with intellectual and developmental disabilities. This data on this slide is taken from the National Core Indicators, and this is a survey that's done of people who are in the service system that have intellectual and developmental disabilities. What it's showing you is that the highest rates of obesity are in the middle age, that's 40 to 59 years old, and especially people who live in the least restrictive settings where they have more freedom, of course, and those are really the ones that we really have to look at in terms of making sure that people are having healthier behaviors. In addition to studying and looking at data on health behaviors, we have also developed through our research and training center evidence-based materials, and in particular is one called Health Matters, the Exercise and Nutrition Health Education Curriculum for Adults with Developmental Disabilities. And another example, this is not one that we've developed, but Steps to Your Health is one that's been developed that also looks at, this one in particular looks at trying to reduce obesity rates. But let me tell you about the Health Matters one that we developed. And originally what we did is we had a 1 hour of health education class 3 days a week. They also had physical activity and nutrition. The curriculum has 36 sessions, a personal notebook and tape. It's all very visual, very much adapted to people with intellectual developmental disabilities. It's really important. It has to be fun. It has to be engaging. It has to be simple and easy to understand. It's based on theories of self-efficacy and social learning. So much of this is embedded in this particular program. Some of the outcomes that we had is people with intellectual developmental disabilities increase their knowledge about exercise, their confidence in their ability to exercise, in their life satisfaction, in fitness levels, physical activity, strength and energy, peak VO2, and stair climbing. Also, the caregiver perception of the exercise benefits went up. With people with intellectual and developmental disabilities, they need to get much support from others around them, particularly families, oftentimes staff that they work with, and we found that access barriers were reduced. But what we noticed is that it's not enough to just bring people into a center and doing exercise with them and teaching them these things, but what's most important is if you want exercise adherence is you really have to go out to the community-based organizations. And you really, so what we did was develop the Train the Trainer program, and we also have a book that goes along with that on how to create the program. In this next stage, what's happening is we're trying to translate what we've learned in the evidence-based research into a scale-up. And the scale-ups are trying to, when we use a re-aim kind of sort of paradigm in terms of really trying to increase the adoption of what's used and the reach of it. And we try to transform the state fiscal and policy capacity, the community and organizational capacity, and the attainment of health goals. And the way we've been doing that recently is, and Beth Marks and Yasmina Cicerak as the leaders of this particular, of the Health Matters at this stage in getting the knowledge translation out there, is establishing communities of practice in 5 states. Right now, the main ones are Alaska, Kentucky, Maryland, Illinois, Missouri. And what they've done in terms of these, trying to get this out there, is doing requests for proposals from different community agencies throughout the state, usually working with the University Center of Excellence in Developmental Disabilities in that state, or maybe their Illinois Council on Developmental Disabilities, and then making sure that these different organizations that apply and get accepted, they have health committees, and what they're doing is building the capacity of these organizations to be able to carry on, and to have people who are trained that can continue this. And this has been a very effective way so that thousands of people can be impacted by this evidence-based curriculum. So this is one example of what we are trying to do in our research and training center to really promote more exercise and more healthier nutrition for people with intellectual and developmental disabilities. I want to tell you about a newer one that we've been doing. This is under the direction of Kelly Hachey. It's called We Walk. And it's a really cool program that it has the concept that people with intellectual disabilities, many of them live at home. It's a walking program for their parents, their family members, and them. And so those are the buddies as they walk together. And so part of the mission is also to improve the health of often the parents, along with the person with intellectual disabilities. And it's a 12-week walking buddy program to promote physical activity. And it uses a lot of technology. It uses a physical activity tracker, a Fitbit, both for tracking daily physical activity, so for a monitoring, but also for text messaging, for coaching, and it uses also text messaging for coaching and feedback. And it's tailored to the preferences of the person with disabilities and also the family member. So there's interviews done before on their goals, on their inspirations, on values, really trying to figure out what would motivate the person. So I would like to just say that in summary, as we start to develop new ways of helping people continue to learn about exercise, to monitor their exercise, and to continue doing that, we can use new technologies that are developing continually. And I think we also have to remember to think about the supports, whether it's staff or whether it's family. It's really important to engage the support. And here's our contact information if you would like any more information on any of this. Thank you.
Hi, everybody. This is Seth Keller. We're passing the baton from colleague to colleague. I'm a neurologist, as was mentioned by Stephanie. I'm a co-chair of the National Task Group. We focus on aging and dementia in the developmental population. I'm also past president of the American Academy of Developmental Medicine and Dentistry. So my perspective coming into this conversation is healthcare practitioners and how they look at this issue. So my partake in this is really very relevant to in that area. And as Tamar was really talking about, this slide mentions about the aging population, and it really is a huge issue. Why are we talking about aging now? Why are we talking about health promotion? Why are we talking about exercise? Well, the truth be told is that back in the day, even in the 20s, people with both intellectual developmental disabilities or Down syndrome in particular, sadly enough, they really didn't live long enough to really reach any ripe old age where even aging concerns were there. But as this particular slide shows, that over the course of decades and going up, you see the pink line is Down syndrome. By 2000, people are living 50, 60 older years old, and those with general developmental disabilities or intellectual developmental disabilities are living longer and longer. So it's hugely very relevant to working with NIH and Go for Life to even want to be on this program to really say, you know, people with IDD have value in great life, and it's important of aging. The challenge, a lot of it is we don't even know, unfortunately, what healthy aging really looks like in someone with developmental disability or intellectual developmental disability, because they really haven't lived long. If they already have a current level of cognitive or physical disability based on what kind of condition they have, is what does that mean as they get older? So we really have to have a sense of what the expected is. Each of us on the phone, you know, as you've gotten older without knowing your ages, have a sense of exactly the way it used to be until now and how you might be, you know, if you don't have any chronic health condition or develop an acquired health condition, what you're going to look like. So how is aging and really the level of function measured, and how do we even know that we're even a difference, whether we're adding exercise or health promotive activities? We have to kind of know, in my respect as a healthcare practitioner, are we really making a difference in changing the outcome of how we live our lives? And as Tamar mentioned, disparities clearly exist. As she was talking about obesity in general population to IDD, they exist in many respects for various reasons in general areas of health. This slide really just is more of a general slide. It's kind of complicated and really just talks about the diversity of aging and how aging of all of us is kind of affected by many different factors. The person in the middle, us, someone, the individual with developmental disability, with all those arrows surrounding it, is impacted by many factors. If you're a man or woman, if you drink or smoke, if you eat well, are you genetically predisposed to health conditions as you get older? Do we have certain organ systems that are actually more prone to the aging process? Are you more susceptible to getting diseases based on your life, or whether you have a developmental disability that might be more prone to certain conditions? And from a social and cultural standpoint, which is really a philosophical, moralistic issue, how are people with intellectual and developmental disabilities living their lives, and how does the cultural, social mores in our society, the United States, have any impact upon them, which might keep them from getting the best way of getting attention to care, which is, again, why Go for Life is hugely important for us to kind of work with NIH. There, intrinsically within all of us, there's the term called plasticity. Plasticity is the ability for our bodies, or our brain maybe in particular, to kind of have maybe some changes in our mind, and as we age, if there's any injury or aging process, can we like roll with the punches in a way? Can we actually modify our brain, or will any kind of injury or aging process of brain have direct impact? So if you have a brain that might be impaired or has some kind of developmental changes within it, theoretically people with developmental disabilities, some may have less ability to modify their brain activity as they get older. Cognitive reserve is the concept, has a lot to do with how do we live our lives from young to getting older, and that has a lot to do with how well do we take care of ourselves when you're younger, education levels, nutrition levels. So in other words, the better care that you are in many respects as you're younger will have a huge impact as you're getting older. So the reserve is really built up over time. The obvious factors that we also look at about what we would call successful aging, meaning how well we think when we're getting older that's best for us, is what are called the modifiable factors for successful aging. And certainly within this is exercise, which is kind of what Go for Life is about in many respects. But general health promotion, which is meant on this particular slide, talks about this, diet, weight changes, stress levels, don't smoke, education, the type of work you do, living in an enriching environment of love and happiness, hopefully, and then basically the kind of environment that you live, nurturing or clean environment, are hugely important. Those risk factors that we can't do much about, unfortunately, is realities of just living life and getting older. You might want to look differently. You could put different glasses on, dress younger, dye your hair, or get contacts or laser surgery, but still or drive a faster car, but you're still going to get older, and you can't change that. Genetics, if we're prone to certain diseases when you get older, you can't change that. And whether or not you're a man or woman basically has greater chances of developing different issues. This slide basically is a general slide, and it kind of elaborates on what Dr. Heller was talking about, of some of the different developmental types of situations that actually are more prone to certain age-related changes. Down syndrome, cerebral palsy, and autism, of those three, have certain propensities to develop age-related changes or complications. And because exercise and health promotive activities are so important, we would like to have the theory that with health exercise or type of health promotive activities, that some of these difficulties of health, if they're prone to them as they get older, will exercise, will health promotion, will living better be able to reduce some of these issues, such as in Down syndrome, early onset Alzheimer's, as Dr. Heller mentioned, gait dysfunction, sleep dysfunction, thyroid dysfunction, obesity is mentioned, sleep disorders, depression, and certainly in someone with cerebral palsy, gait dysfunction, chronic pain, swallowing dysfunction, bladder and bowel difficulties, esophageal swallowing dysfunction. It's very, very much important to appreciate that health promotion and even exercise can actually help to reduce some of these potential complications in health, which certainly if they arise in the individual, you can only appreciate how much they might have a negative impact in their quality of life. Someone with autism, which is a really heterogeneous population of autism from very mild to profound, might, as they get older, might change. Seizures, accidental death. Autism is such a heterogeneous population of people, it's somewhat difficult to always predict how age and age-related decline or even health promotive activities will have any effect in terms of reducing some potential complications later in life. This slide really talks about the realities of what can happen as you're getting older. And as a neurologist, for me, my middle name is brain. Brain, brain, brain. I talk about the brain, talk about the changes that happen. And this slide really talks about the aging brain and the consequences that eventually may have an impact upon the possibility of developing dementia. And what happens is that as we get older, we develop good practices. Hopefully we're taking care of ourselves. But as we get older, there are certain factors that we actually may be acquired: stroke, head injury, alcohol, stress. But if you then attack it early on, health, diet, exercise, don't drink, take care of yourself, then basically you might slow down the aging process, or in fact, maybe even slow down the time of when dementia may occur, or the severity of dementia may occur. And certainly this is very relevant in early onset Alzheimer's and Down syndrome, to think about health promotive activities early on that certainly may, and that's the important part, may reduce the risk of those high risk of getting dementia, Alzheimer's in the population. Right now, the fact that there's so much we don't really know about aging and exercise in an objective way. Our colleagues on the phone and call tonight, Dr. Heller and actually Darcie, who's talking certainly from a huge standpoint about Special Olympics, is really doing so much about reducing health disparities, understanding about exercise, the importance of exercise. But the one thing for me and my colleagues in medicine is, how do we really talk to individuals about exercise and health promotion? What are the standards at which any practitioner may be looking about how to care and support someone? What's the educational parameters? And certainly what we're doing on today's call is beginning a dialogue and inviting people on to talk about it. But certainly what's also very important in the future of care in this issue is coordination. As many people can appreciate, exercise, diet, health promotive activities certainly are great individually for people themselves, which is important to them, but certainly in someone that may have a disability, developmental disability, they often need the coordination of support staff, families, organizations, people all working together, a team approach for the best success and be able to achieve the goal of promoting and having successful practices of care and health promotion. So communication is hugely important, as well as certainly the interdisciplinary care efforts. People with developmental disabilities have been fighting for civil rights, the rights to have the best practices for them as people and individuals, to be able to think of them as any rightful citizen in the United States, to have this type of activity, this kind of education to be talked about. Usage of technology is hugely important, that we're going to be looking at about monitoring, measure, and helping people with exercise and health promotive activities. But we do need data. There's got to be research. We need research and data to hugely impact and know whether or not our health promotive and exercise recommendations, what are they really doing? What are the right exercises, or do we need to monitor or measure or modify exercise activities to make sure that it's the right thing? And is it really age appropriate or appropriate toward the developmental disability in the types of exercises that are age related and appropriate? Is someone that's getting older with a developmental disability, are they able to kind of keep with the same activities and exercise? And I know that Darcie will be talking a lot about this within Special Olympics. The key thing also for education, training, and support for healthcare practitioners is really financial, to be honest with you, because in a lot of cases, practitioners who support people for developmental disabilities may not get issues of financial support to support and care for chronic complicated individuals, and sometimes if the individual might have Medicare or Medicaid or even non-insured, unfortunately a lot of practitioners, because of the lack of understanding of developmental disabilities, thinking of them as complex individuals, and they haven't maybe been trained and appreciate the complexities of communication or ability to support and care for them, then it's a real complicated issues. So education is really important, but also making sure that practitioners can get supported through managed care organizations, centers of Medicaid, Medicare services. So a lot of it in terms of the future where we're going to go is really across the board. But starting with this kind of conversation today is really right up in what we want to talk about. So thank you very much, and hopefully we'll have time for questions.
Great, thank you, Seth. This is Darcie Mersereau, and I am going to, everybody seeing that? Nope. Okay. So I want to talk from the perspective of a service organization that's out in the community working with patients and individuals with intellectual disabilities. And hopefully many of you are in places where Special Olympics is present, and there might be some collaboration opportunities that I would look forward to talking with you more about. Just a little bit briefly about our organization. Special Olympics is a global organization that provides sports training and competition opportunities for children and adults with intellectual disabilities. We are in 169 countries, and we're almost 4.7 million athletes strong at this point, including about 750,000 in the United States. We do take a lifespan approach in Special Olympics, beginning with at age 2 with our Young Athletes program, following through with a heavy focus on school-based programming, and then continuing with community-based programming for older athletes. Just for a frame of, obviously we cover every age, but in the U.S., about 37% of our athletes are over age 22. And as Seth said, we think about aging a little at a slightly earlier age in Special Olympics because of the early onset of chronic diseases in this population. The other thing that I think is important to know is that Special Olympics really does engage a broader community of volunteers, of families, of athlete leaders and peer educators, of youth leaders, very, very strong presence in the school system in the United States. And it takes a unified approach where we're pairing people with and without intellectual disabilities in the same teams, in the same activities. And so even though it's a relatively small population, the population of people with intellectual disabilities, but through Special Olympics we do engage a much broader population than if we were focused just on people with intellectual disabilities. And then the other thing about our organization is that it's not an elite sports organization. Some of you may be familiar with, many of you are probably familiar with the Olympics, some of you may be familiar with Paralympics. Those are both elite sports organizations. Special Olympics is really a community-based recreational sports organization. We do about 300 competitions around the world every single day, and we, as a result, are targeting people of all ability levels, including people who might not consider themselves athletes. There is a place for everyone with intellectual disability in Special Olympics, including people with intellectual disabilities who have other physical or mobility or sensory disabilities as well. We have chosen over the last 20 years to augment what we do in Special Olympics, our sports training and competition program, with some health programming. We do about 900 clinical screening events every year. About 450 of those are in the United States. At these events, we provide screenings basically to identify conditions that have gone untreated or even undiagnosed in our population. For a whole range, there's a whole range of reasons why conditions don't get diagnosed in this population, alluding back to some of what Seth was talking about with training of, it starts with the training of healthcare providers. Most of them have not had any training working with this population. So, it's not uncommon for us to have, to find someone with stage 3 hypertension who didn't know that they had any issue with their blood pressure. It happens often, and so that's something that we try to do. We educate athletes on prevention. We're able to provide some services through partnership, including some physical therapy, eyeglasses, on-site dental care, hearing aids. These are all things that are critical to, it may seem a little weird that a sports organization is doing this kind of health work, but we literally have athletes who cannot see the finish line until they come to Healthy Athletes and get glasses. When you think about the fact that many of our athletes can't see well, can't hear well, have other kinds of conditions that are causing pain, it's not surprising that this inhibits interest or ability in physical activity and exercise. We, in doing these events, we recruit healthcare professionals from communities where the events are held. So we don't like fly in a team and do a clinic and then leave. We train people on the ground in those communities to pull off the events. And the goal there is that people, our clinic maybe is 1 day or 3 days, and these professionals are in the community year-round after our event leaves. And so we work with physical therapists, we work with MDs, we work with a range of optometrists, podiatrists, a range of professionals to make sure that they understand the kinds of special health needs that people with intellectual disabilities have, but also feel more comfortable talking with them. How do you talk to somebody who has a different cognitive ability? How do you talk to somebody who's nonverbal? It's really important, and the health professional plays such a vital role in physical activity and exercise. If they're not comfortable with this population, then they are not going to counsel them on it. And so that's an important part of what we do. We collect the data at every single event so that we have the ability to talk about the health of this population to people who are in positions of power and have the ability to influence broader system change than beyond what we can do at our events as a sports organization. And so that data, those data are available and to work with outside scholars for analysis and dissemination and building the knowledge base. We have, in the last several years, expanded beyond what we do at our screening clinics and what we do in our sports training and competition to also offer year-round kind of physical activity and wellness and prevention programming. We do that through engaging our athlete leaders, our family leaders, other community volunteers. Going back to what Tamar was saying, this is a way of making sure we're engaging the support network around the athlete, in many cases the people who would take them to the gym or who themselves might have healthy, have lifestyle behaviors or issues they need to work on, but to create an environment in which it's easier for the athletes to be physically fit and active. A key aspect of this is our fitness program, and it can range from walking clubs to that we have some family-oriented fitness programming to other kinds of fitness programming. I think this is particularly interesting to this group and to Go for Life because fitness is something that may be interesting to older individuals who are no longer interested in competitive sport but are still interested in being part of Special Olympics or being fit. And we, even more recently, in the last couple of years, have started working with other community organizations. And what we're doing at the local level is reaching out to organizations in communities who have influence over health, whether they're policy makers, whether they're universities, medical schools, dental schools, nutrition programs, whether they are providing services in the community, they are doing research, and asking them to begin doing what they do more inclusively. So passing policies that are more inclusive for people with ID, running programs that are inclusive for people with ID. It's really interesting in these conversations. What we find is that people, a lot of people who have a population-based focus think that because they are reaching everyone that they are also reaching people with ID. And they just, I mean, it's understandable, right, because it's a small population. They just don't know, they don't even know what the gaps are, and they don't even know that they're not reaching or why they're not reaching or how they could make themselves more accessible so that they would reach people with intellectual disabilities. And I think it's, and part of the thrust behind this, as Tamar was saying, is it's, you know, it's not just about creating parallel programming in Special Olympics, but it's really making sure that we're working with organizations who may directly support Special Olympics athletes or may never directly support Special Olympics athletes, but if they take on inclusion, it's going to have a much bigger systems impact for everybody with intellectual disability, regardless of whether they participate in Special Olympics. So this is a picture from Arkansas of the Arkansas Hunger Relief Alliance, which is partnered with, they use the Cooking Matters curriculum, and they've partnered with Special Olympics in Arkansas to adapt their curriculum so that it's inclusive for people with ID. And then kind of at a step beyond the community level, we're doing sort of the same thing nationally with organizations and individuals who are key health influencers. Right now, our focus is on organizations who are influential over healthy weight of population. That is one particular area, as Seth and Tamar both referenced, that's a huge area of disparity for this population. And, you know, so as we're working with medical schools, health professions training programs, existing healthcare provider organizations, NGOs, corporations like fitness club chains, government agencies, insurance companies, and associations to try to get them to become more inclusive. And, you know, some of it is because it's the right thing to do. Some of it is because we really think that doing healthcare, primary healthcare and prevention programming right for people with ID saves money. They are a big part, they are a small part of the Medicaid population, for instance, but they account for a huge portion of Medicaid costs. And so we think that there are ways to do healthcare better for this population and save money. The picture up here is one example of a partnership that we have formed with the American College of Sports Medicine, and the partnership includes that organization looking at their continuing education that they do for personal trainers, and making that inclusive so that personal trainers feel comfortable and knowledgeable about how to provide care for people with ID. And for Special Olympics, our partnership involves them of assigning fitness coaches to our sports teams so that there's someone focused not just on sports skill development with our athletes, but also on development of fitness. And we're also working on a collaborative research agenda. As Seth pointed out, there's very little that's known about the health of this population. So, you know, I know that a lot of people on this call are focused on delivering services in communities who might include some older adults with intellectual disability. And obviously, I think one way that we could collaborate is being able to refer your clients who have intellectual disabilities to Special Olympics if they aren't already participating. But, you know, if there are people on this call who have other connections, they're clinical educators, you know, training medical students, or service providers in the community, funders, people who are funding things, again, to Seth's point, so little programming includes people with ID in the inclusion criteria for the grant opportunity. And in fact, in research especially, they're often removed. They're often excluded from participation because they're seen as a vulnerable population, so we just don't know that much. There's a whole host of policies that could be put in place that would make health more accessible and higher quality for people with intellectual disability. Curricula need to be changed. Health insurance companies need to change financing. And all of this, and again, the data set that we have, we're Special Olympics. We're not a research institution. We have a ton of data we've collected. We have very limited capacity to do anything with it. And so we're always looking for partners who can help us understand the data, including data on physical activity in this population. So those are some ideas of possible areas for collaboration, depending on where you're coming from and what your interest might be. And my contact information is at the bottom. And so I will wrap and pass this over back to, I guess, to Seth.
Stephanie. I think Stephanie's going to finish up with it.
Stephanie has a couple more comments, and then we are going to do some Q&A. And I'm looking for Stephanie in the...
I'll take it.
Okay, thank you.
So right now we have a Q&A, and we're going to take questions and look at the ones that have come in. We've asked you to, well, you know that you can send in your questions through the chat.
Yeah, so far, Stephanie, there's no questions yet.
There are no questions yet. Okay.
Yeah,
Well,
well, please help at the bottom. There's the chat, and please put it in. Stephanie, can I actually just throw out something, then maybe open up for a question?
sure.
Yeah, I think one thing as everyone's listening on the call, I'm making an assumption that people on the call are sailing into the ID population. Otherwise, maybe they want to learn more or are involved already. What I think is hugely important is Go for Life as well. And I'm going to actually turn the question maybe back to you, Stephanie, not to put you on the spot. Where do you see national or federal efforts like Go for Life to do like what we did today with this webinar, but perhaps more within certain populations, whether it's developmental disabilities or others? Where do you see yourself or Go for Life in terms of advancing or doing more types of nuance or detailed material like on your website or Go for Life?
Are you talking about tailoring it to certain populations?
Sure. Yeah, absolutely.
One thing which you're looking at doing this year as we move forward is I was very interested in what Tamar said about her communities of practice. We're looking at the Go for Life materials that we have, and I introduced a few of them at the top of the webinar, and kind of repurposing them for use in local community-based settings, such as, for example, congregate feeding centers, congregate meal centers, where people come to get meals every day. Low-income people come to get meals every day under the auspices of Meals on Wheels. We're looking at working with the Villages movement, the Senior Villages movement, to try and see how Go for Life activities could be tailored to that population. And we're also looking to work with hospitals, which have often many hospitals have ongoing classes for older adults who've been discharged from hospitals or who have been somehow involved in the orbit of the hospital, and they have classes in which health promotion activities are important. And so Go for Life can be tailored to those populations, to those small kind of pilot projects, to see how they might work on the ground in areas that are not gymnasiums, that are not organizations that are devoted to fitness. So we're trying to find different ways to have Go for Life become self-sustaining. The idea of older adults exercising on a regular basis in a self-sustaining way is what we're going to be trying to do this year. Also, we're going to be looking at ways in which we can bring in information on behavior research to focus on greater amounts of exercise adherence. As I said in my introduction, motivation is a key component of Go for Life. And there's a lot of good research out there that we think may be able to be infused into some of our materials and our messaging to try and get at that whole area of how do you get somebody off the couch and keep them exercising and deal with those issues of motivation, which are so endemic, really, to the whole focus on fitness. So those are some of the things we're trying to do to try and tailor some of the materials to different organizations, to different groups of populations at different need levels.
Now, Stephanie, I was going to take what you just said. You said something so important, exercise adherence. And actually, based on having Tamar as well as Darcie on the call, I think is very relevant to kind of what you just said. And maybe just briefly, Tamar, can you talk about some of the nuances within exercise adherence, within the developmental population, mentoring, self-efficacy, role modeling, those kinds of things, briefly, Tamar?
No. Just to give you a little history, is when we were developing the Health Matters program, and it actually part of the funding came from the National Institute on Aging through the Roybal Centers, in addition to, at that time, NIDR, National Institute on Discipline and Rehab Research. And one of the comments that I got was that these people, meaning people with intellectual disability, wouldn't be able to benefit from social learning theory and Bandura's ideas of self-efficacy. And of course, what we found is that they very much benefited from being able to look at using social learning kind of theories, at looking at expected outcomes, that they knew that what they were doing would make a difference for their life, and also that they could see themselves actually doing something, so that they were able to perform and being able to do that. So that was really the first step in exercise adherence. But the second step in exercise adherence was to getting the supports in place. And we thought just bringing people in, like family members, and that they would be part of the training would be good, or staff, but that turned out to be not the best way either. What really was important was to go out to agencies where they're working or where they're living, and then getting the staff excited about it and looking at the capability of the organizations themselves. And we found in looking at goal attainment that only when they were getting that support did anything really happen. And so that's been such an important part. And then you have to make sure that you have the support way at the top in these organizations.
Absolutely.
So that's a piece of it. And otherwise, you know, you see things like, you know, vending machines that are full of candy bars, and you know, you see staff that are, you know, very overweight and maybe serving food that's not good for people. And so you really has to be a whole culture around it. And I think that's looking more and more at those environmental and community aspects. And another piece of it, which is really interesting, and this is some work that Yochai Eisenberg is doing along with Jim Rimmer, is they're looking at the environment, and they've developed this community health index through some grants from CDC, and that's also, if you want exercise adherence, you have to have places where you can walk, and disability-friendly and healthy-friendly communities.
Now, also from your standpoint, Darcie, in terms of Special Olympics, I don't know if it would be unified sports or others, where do you see exercise adherence within Special Olympics being very relevant to ensure that athletes continue to be involved and engaged and such?
Yeah, so I think what we have seen is that athletes tend to participate in Special Olympics historically for about 12 years. Usually, it's not an uncommon time for them to leave around age in the mid-20s for reasons that are quite similar to the reasons why other people discontinue competitive sport. And, you know, they have jobs, they don't, you know, they did sports through school, but once they're out of school, that's not what they do anymore. But there can be other reasons, including onset of pain and other kind of chronic diseases. And that's where I think a lot of the fitness programming has really started to fill in a gap in Special Olympics, because it does resonate with older athletes, particularly ones who are dealing with weight issues or chronic disease. And what we're finding is probably, I mean, we're not scholars, we're not doing a lot of research, but what we find is very similar to what we see in literature, which is athlete peers are very influential on adherence. Coaches are very, very influential in Special Olympics. Parents are less so. I mean, except for our younger athletes, parents are less influential. And engaging, as Tamar said, the settings where athletes live is really important. A lot of people with intellectual and developmental disabilities live in group homes or other settings where they're living with staff rather than family members or independently. And so if the staff are not on board, it's really hard to move forward. And so interventions that target, in Special Olympics, interventions like our fitness interventions that target the whole family or the living center tend to be better in terms of adherence. The other thing, we are also, like Tamar, looking at and doing some passive data tracking to make sure that we're seeing, because Special Olympics is usually 1 or 2 days a week, which is, of course, not sufficient from a physical activity perspective. And so we do have an increasing amount of home stuff that athletes can do outside of their participation in Special Olympics that's adapted for people with intellectual disability, and we're starting to use passive data tracking to see if they're actually doing it.
Yeah, thank you, Darcie. We have just like another 5 minutes, so please, if there's any other questions, please add. And also what I was going to add, just to kind of throw into the mix certain things that we think about, is again, what makes someone with a developmental disability maybe unique in the challenges that they really face as they're getting older. One would be the aging care provider, whether that's an aging parent or a sibling. It's not a small issue. It actually can be a very huge issue. So a lot of people with developmental disabilities may have always lived with mom or dad, and now mom or dad are now in their 70s, 80s, etc. And the individual with the developmental disability is now 40s and 50s. You can appreciate what that may mean for the individual who's aging with developmental disability, who's mom or dad, who has their own age-related issues and their own cognitive or physical problems, on how that may impact upon them supporting or caring for the person. So that's not a small issue at all. So we do have to appreciate the background, the backstory, the social issues, the psychological issues that really take part. And the other sad part is stereotypes. There's a lot of unfortunate stereotypes with developmental disabilities, as alluded to in the conversation, about, oh, they can't do this and they'll never be able to do this. And certainly with aging, oh, there's not much we can offer them and they can't adhere to this. And it's nonsense. So I really think a lot what has to be overcome is biases and stereotypes, which is a huge issue. And so for people in the field, and again, probably for everyone on the call perhaps, gets it. So I think everyone probably does appreciate advocacy, the importance of strong advocacy and fighting for the rights and realities, just like we want for Go to Life to kind of be part, and for us to kind of be part of them, is really, we should be. Everybody with developmental disabilities should be part of mainstream U.S. national agenda, should all be there. So that's kind of my soapbox preaching in the closing moments. Stephanie, we had...
I have a question for a couple questions for Darcie, if I could.
Oh, please go ahead.
Darcie, you mentioned that you have a fitness program for your older, that older Special Olympians might be interested in it. What does a fitness program consist of?
So it's what we do in Special Olympics is for fitness is we have 3 models for fitness that we've put out to our field offices around the U.S. and around the world, and they can adopt one of those 3 models, and they are not specifically targeted at older athletes. It just so happens that is the group that tends to engage with it more. So what we're seeing is people who don't want to, maybe we're at risk for dropping out of Special Olympics for a range of reasons, are moving over to fitness.
And so those programs are focused on what, the 4 different activities that Go for Life talks about in terms of endurance, strength, flexibility, and balance?
Flexibility and balance. Yep.
Okay. And does it involve personal trainers?
Typically, no, it doesn't, and that's something about, that's a little bit the nature of the beast with Special Olympics, is that we're a grassroots volunteer-run organization. However, one of the things that we are doing through partnerships with American College of Sports Medicine and other organizations is trying to put fitness coaches on teams, and in many cases those will be trainers.
Great. And one more question. I was wondering if a fitness trainer was to be trained to work with people with IDD, what are the different approaches they might have to take? I know it would depend certainly on the condition of the person with IDD, but in general, what approaches? Is the approach to training for that population different from a population that doesn't have IDD?
A big part of it is knowledge of what kinds of issues someone with Down syndrome might face, and laxity of muscles or other kinds of issues that could mean that doing exercise safely means different kinds of exercises, for instance. And so knowledge of that is important. Other things are not necessarily specific to training, but more how you talk to someone who has intellectual disability. Seems obvious, but in fact, people get intimidated. When they're intimidated, uncomfortable, unsure, people end up talking to the mother of the athlete instead of to the athlete themselves, and the athlete is left feeling marginalized or excluded. Some of our athletes are not verbal. Some of our athletes can't read, and so it's a lot of it is communication skills more than specialized knowledge and personal training. However, the specialized knowledge is understanding the range of health issues that a client with intellectual disability or an individual with intellectual disability might come with that wouldn't be as common in the general population.
Thank you very much. Are there any other questions?
Stephanie, can I just add one thing to that? And it's really, I guess, back to a question to Darcie. And Darcie, as you certainly know, my interest in geriatrics and the aging athlete is certainly there, as you know. aging athletes are getting older, they're staying around longer. What is your view, Darcie, in terms of maybe the future of attention or focus on the aging athlete in terms of where Special Olympics might be moving in the future? Any sense about that?
Yeah, I mean, sure, because we're a mission-driven organization, and it breaks our heart to think that there are people with intellectual disabilities who could benefit from our programming and aren't taking advantage of it. And it is causing us to, look at why do people leave competitive sports organizations, and are there things we can do to retain them, including fitness programming. And so
Right.
it's a conversation that's happening in the U.S. more than in a lot of in other countries. A lot of our programming is school-based. In the U.S., it's got a very heavy community-based focus. And even though our population isn't as old as the population that many people on this call are working with, it is increasing.
That's great to hear. Wonderful. Thank you so much. Thank you.
Well, I think we've come to 2 o'clock and basically the end of our webinar, and I'd like to thank all of our speakers, Dr. Tamar Heller, Seth Keller, and Darcie Mersereau for giving very insightful and very interesting presentations, and also to Seth for moderating the Q&A. So we really, Go for Life really appreciates all that you've done to help pull this webinar together. And just a great big thank you to all of you, and also to the audience out there who's been listening. We really appreciate you coming in and participating in the webinar and taking in the information. Let me just enlarge my screen.
And Stephanie, thank you so much for all the work and help that you've done.
That's right. Thank you for giving us
and
this
Jerome,
opportunity.
Jerome, our behind-the-scenes quiet guy there. Thank you, Jerome.
And let us know if you have any ideas for webinar topics, or if you'd like to host a webinar of all the partners out there, because the partner webinars are for you, and we think that there's lots of information that all of you have that can be mutually mutually helpful. And so if you have an idea for a webinar or would like to co-host a webinar in the next few months, just give me a contact at dailys@nia.nih.gov. I'll be happy to talk with you about how we could set something like that up. And it's very important to remain connected with us, mainly through our website, and go there and find all the wonderful materials we have to offer to all populations, all older populations who are interested in staying fit as they get older. And once again, thank you very much, everybody. Goodbye.
Thank you, guys. Thank you all.
Thank you.
Bye-bye.